picture this scenario because it actually happens way more often than you'd think in the high-stakes equine world.
Oh, yeah. Constantly.
Right. So you have this multi-million-dollar warm blood, like a Grand Prix dressage prospect, and it arrives at a top-tier veterinary clinic.
And the owner is frantic.
Totally frantic, because over the last 3 weeks, this incredibly athletic animal has started subtly dragging its right hind toe.
Just a microscopic delay.
Exactly. Just this tiny delay in the protraction of the limb, and then a slight head tilt appears.
Which is terrifying to see.
It is. So you're the attending veterinarian, you look at the horse, and your mind immediately goes to the usual suspects for, asymmetrical neurological deficit.
Right. You start running through the list.
Yeah. So you prep the horse for a lumbosacral spinal tap, you slide the needle in, perfectly bypassing the venous sinuses, and you draw fluid that is just crystal clear.
That's perfection.
Not a hint of pink. And you send that cerebrospinal fluid off to the lab for a Western blot to check for, well, our primary topic today.
Yeah.
3 days later, the lab report comes back glowing red, positive. So you diagnose the horse, you start this aggressive, incredibly expensive treatment protocol, and you tell the owner, like, hey, we caught it. But a month later, the horse is significantly worse. And eventually, tragically, the horse has to be euthanized.
It's just devastating.
It really is. But here's the kicker. When the pathologist does the necropsy, they find absolutely zero evidence of the parasite you treated for.
None.
None at all. Instead, they find cervical vertebral stenotic myelopathy.
Basically a physical compression of the spinal cord in the neck. Wobbler's syndrome.
Right. So the test you ran on that perfectly clear spinal fluid was completely unequivocally wrong.
It's a devastating scenario. And I mean, it perfectly encapsulates why the diagnostic landscape we are navigating today is probably one of the most treacherous in modern veterinary internal medicine.
Which is exactly why we are wading right into the deepest part of those diagnostic muddy waters today. We're doing a deep dive into the PhD level complexities of Equine Protozoal Myeloencephalitis, EPM. Okay, let's unpack this. Because if you're holding a lab report for your horse right now, or if you're a clinician staring down a confusing case, we need to completely dismantle how you interpret those results.
Absolutely. You have to throw out the old assumptions.
Right. This deep dive is about the biological reality of false positives. It's about the physical limits of diagnostic testing and this massive, fascinating minefield that veterinarians have to navigate just to mathematically prove a horse actually has this disease.
Yeah. And to truly understand EPM, we're going to have to connect the dots between parasitology, advanced equine neuroanatomy, and, well, highly complex quantitative immunology.
It's a lot.
It is a lot. I want you to approach the stack of sources we're utilizing today, which range from the American College of Veterinary Internal Medicine consensus statements to these multi-year epidemiological surveys like you are a veterinary internist solving a high-stakes puzzle.
Because things aren't what they seem.
Exactly. In this specific field, the face value of a test result is almost never the whole truth. We have to look past the binary positive or negative and understand the actual physiological mechanics driving those results.
Right. And, to catch a killer, or in this case, to diagnose an incredibly elusive pathogen, you first have to understand its origins, its biological imperatives.
We're primarily tracking a protozoan parasite called Sarcocystis neurona.
And as a secondary culprit, Neospora hughesi, right?
Right. But let's focus extensively on Sarcocystis neurona first, just to establish the baseline, because its life cycle really dictates the entire epidemiological pattern of the disease.
Okay, let's get into it.
So S. neurona is an obligate intracellular parasite.
Meaning it has to live inside a host cell to survive.
Exactly. And it requires a strict two-host life cycle to propagate. It alternates between a definitive host and an intermediate host.
Okay.
The definitive host is the organism where the parasite achieves sexual maturity and reproduction. And in North America, the primary definitive host is the Virginia opossum.
Just your standard everyday opossum.
Didelphis virginiana.
So the parasite's endgame, like its actual reproductive phase, is happening entirely within the opossum's gut.
Precisely. The parasite undergoes gametogeny, which is sexual reproduction in the opossum's intestinal epithelium.
Wow.
Yeah. The opossum then sheds the resulting sporocysts in its feces. And, we are not talking about a small amount of shedding.
Oh, right.
We're talking about massive environmental contamination. These sporocysts are incredibly resilient.
Like how resilient?
They can survive freezing, they can survive desiccation, and they can persist in pastures, haylofts, and grain bins for months.
Which perfectly sets up the next phase,
Yeah.
because the parasite doesn't want to go back into another opossum right away. Right?
No, it needs an intermediate host to continue the cycle.
Okay.
The parasite's evolutionary goal at this stage is for those environmentally resilient sporocysts to be ingested by a specific range of intermediate hosts.
Like what?
We are talking about skunks, raccoons, armadillos, and even domestic cats.
Okay, so the skunk eats the contaminated food, then what?
Once inside the intermediate host's digestive tract, the sporocyst ruptures. The emergent sporozoites penetrate the intestinal wall, they enter the endothelial cells of the blood vessels, undergo massive asexual replication, and eventually travel to the skeletal muscle tissue.
So they basically take a tour of the bloodstream until they hit muscle.
Exactly. And there, they form dormant cysts called sarcocysts.
They just wait. They build a little bunker in the muscle tissue of the raccoon or the skunk and go completely dormant.
They wait for the intermediate host to die.
Wow. Dark.
It is.
Oh.
Because the cycle is only completed when an opossum comes along, acts as a scavenger, and consumes the infected muscle tissue of that dead skunk or raccoon.
Okay, so a possum eats dead skunk.
Right. The sarcocysts break down in the opossum's gut, releasing bradyzoids, and the sexual reproduction phase begins all over again. It is a perfectly closed, highly efficient ecological loop.
Okay, so looking at this incredibly specific of opossum to skunk to opossum loop, where on earth does the horse fit into this?
It doesn't.
Wait, what?
Biologically speaking, the horse is a complete evolutionary anomaly in this cycle.
A mistake.
Total mistake. A horse grazing in a contaminated pasture or eating contaminated hay ingests the opossum shed sporocysts exactly like a skunk would.
Right.
The sporocysts rupture in the horse's gut, and the parasite attempts to follow its programming. But the equine physiological environment is completely alien.
So it gets confused.
Basically, the parasite cannot form viable sarcocysts in equine muscle. The horse is a true dead-end host.
Wow.
Yeah, it cannot shed the parasite to infect other horses, and because opossums do not typically scavenge equine carcasses.
The parasite is just trapped.
Exactly. It has essentially written itself out of the gene pool by entering the horse.
It's a fatal biological mistake for the parasite. But I mean, if the horse is just an evolutionary accident, a total dead end, we have to look at the massive prevalence of this disease and ask some serious questions. Like, if a farm has impeccable biosecurity, their feed is locked down, they have aggressive wildlife fencing, and they are still seeing neurological cases, is this solely an opossum issue, or are we underestimating the spread?
You're highlighting exactly why the geographical and epidemiological data has been shifting so radically.
Yeah.
For decades, the prevailing veterinary wisdom was that EPM was strictly confined to regions with heavy opossum populations.
Makes sense.
If you were in a region without a natural opossum reservoir, the assumption was your horses were safe. But recent data completely dismantles that assumption.
Like the Alberta study.
Yes, take the 2024 study out of Alberta, Canada that we have in our source stack.
The one focusing specifically on resident horses, that distinction is crucial.
It is the linchpin of the study. They didn't look at horses that shipped south to Florida or California for the winter competition circuits.
Because those horses could have picked it up down south.
Exactly. They selected 116 horses that had never left the province of Alberta. Now, the environmental climate in Alberta is hostile to the Virginia opossum. They don't have an established endemic population there.
Right. Too cold.
Yet, when they ran the serological assays, they found a much higher than expected seroprevalence to both S. neurona and N. hughesi.
Which implies one of two things. Either the sporocysts are hitchhiking into Alberta on imported hay and grain from the United States in massive quantities.
Or we have unidentified definitive hosts operating outside the opossum paradigm.
That is wild.
It completely rewrites the risk assessment for clinicians in northern latitudes. You can no longer dismiss EPM just based on your zip code.
Wow.
And the Alberta study also brings us to the secondary culprit, Neospora hughesi.
Right, because we know S. neurona relies on the opossum and environmental contamination, but N. hughesi operates under a totally different set of rules, doesn't it? The sources indicate its life cycle is still a significant mystery.
It is a profound mystery. We do not definitively know the complete life cycle of N. hughesi.
So we're just guessing.
Well, we extrapolate heavily from a closely related organism, Neospora caninum, which primarily affects cattle and dogs.
Okay.
Based on that, the working hypothesis is that caninids Coyotes, foxes, domestic dogs might serve as the definitive hosts for NHUC.
Interesting.
But what we have definitively proven, and what changes the clinical landscape entirely, is the route of transmission in horses. NHUC is capable of transplacental transmission.
Vertical transmission.
Yeah.
Meaning a mare who is infected, even if she is completely asymptomatic, can pass the parasite directly across the placental barrier to her foal in utero.
Correct. With S. neurona, every single case is a new, independent environmental exposure. But with NUZ, a breeding farm could theoretically have a generational inheritance of the parasite passing from mare to foal.
Completely independent of external environmental contamination or wildlife factors.
Exactly.
That makes the biosecurity aspect infinitely more complicated. You aren't just fighting the environment, you're fighting the genetics of your herd.
It's a huge challenge.
But let's bring this back to the pathology of the individual horse. Regardless of whether it's S. neurona from an opossum or N. hughesi, once the parasite is in the horse's gastrointestinal tract, how does it actually get to the brain?
Good question.
Because the blood-brain barrier at the BBB isn't just a physical wall, it is a highly selective, actively defended fortress.
The pathophysiology of how the parasite breaches the blood-brain barrier is critical. When the spore cyst ruptures in the gut, the sporozoids penetrate the intestinal epithelium and enter the systemic circulation.
Right.
Now, the BBB is composed of specialized endothelial cells with extremely tight junctions, surrounded by a basement membrane and astrocytic end feet.
Basically a microscopic vault.
Exactly. It is designed to keep systemic pathogens out of the central nervous system.
So how does a comparatively massive protozoan punch through that?
There are two primary hypotheses supported by the histopathology. The first is direct endothelial infection. The parasite infects the endothelial cells, lining the capillaries of the brain and spinal cord, replicates within them until the cell ruptures, and literally spills directly into the neural parenchyma on the other side.
Whoa, just blowing up the wall from the inside.
Yeah. The second, and perhaps more insidious mechanism, is the Trojan horse model.
Hijacking the host's own immune system.
Precisely. The parasite infects peripheral leukocytes, basically monocytes or macrophages.
White blood cells.
Right. These white blood cells naturally possess the ability to cross the blood-brain barrier through a process called diapedesis to perform routine immune surveillance.
Oh, I see where this is going.
The parasite simply rides inside the leukocyte, completely hidden from the plasma antibodies, and is carried directly into the central nervous system.
It uses the horse's own security guards to bypass the security checkpoint?
Exactly.
That is terrifying. And once it gets past that barrier, we hit part 2, the clinical chameleon. Because once the parasite is inside the spinal cord or the brainstem, the damage it causes isn't uniform.
The clinical presentation is notoriously chaotic. When you review the ACVM consensus statement, the defining hallmark of EPM is multifocal or asymmetric central nervous system disease.
Right.
It does not look the same from one horse to the next.
Let's break down exactly what that looks like in the barn. If I'm watching a horse move and I'm looking for the textbook signs, the sources emphasize progressive asymmetric ataxia.
Let's clearly define what that means clinically. Ataxia is a proprioceptive deficit. The horse loses the absolute awareness of where its limbs are in space.
It's wobbly.
Right. But unlike a symmetrical spinal cord compression where both hind legs might be equally uncoordinated, EPM damage is patchy.
Patchy how?
The parasite is creating focal areas of intense inflammation, vasculitis, and cellular necrosis, wherever it happened to land in the gray or white matter of the spinal cord.
So you might have severe lesions on the right side of the spinal cord at the level of the 3rd cervical vertebra, and then another lesion on the left side at the 2nd lumbar vertebra.
Exactly. And this translates to extreme asymmetry. You might see a horse that circumducts, swings wide its right hind leg, but places its left hind leg perfectly normally.
Weird.
You will also see profound asymmetric muscle atrophy.
The rapid muscle wasting.
Yes, because the parasite frequently attacks the gray matter, which houses the lower motor neurons. When a lower motor neuron dies, the specific muscle fascicles it innervates lose their trophic stimulation and rapidly waste away.
So you will literally see a horse with a perfectly muscled left gluteal region and a deep concave divot on the right gluteal region where the muscle has completely atrophied in a matter of weeks.
Exactly. It's striking when you see it.
But those are the textbook cases. The sources are very clear that EPM can mimic almost any neurological condition.
It's called the great imitator for a reason.
The ACVM highlights cranial nerve involvement. A horse might suddenly develop a severe head tilt, indicating vestibular nerve damage.
Or they might develop unilateral facial nerve paralysis, where one ear droops, the eyelid sags, and the muzzle is pulled to one side.
Or dysphagia, right, where the glossopharyngeal and vagus nerves are damaged and the horse suddenly cannot swallow food or water.
Right. It requires a highly skilled clinician performing a meticulous neuroanatomical localization exam. They have to assess every cranial nerve, perform placement tests, evaluate the horse walking up and down hills, and pull on the tail to test for symmetrical resistance.
Because you have to differentiate it from the other major players. Like, if I have a horse that is severely ataxic in the hind end, my brain immediately goes to equine herpes virus 1, the neurologic strain of EHV1.
You're sure?
How does a clinician separate EPM from a viral encephalitis just by looking at the horse?
This is where understanding the systemic response is vital. EHV1 typically causes a diffuse symmetrical vasculitis in the central nervous system.
Symmetrical being the key word.
Right. Therefore, you see symmetrical paraparesis, equal weakness in both hind legs. EHV1 also frequently damages the pudendal nerve uniformly, resulting in a distended, paralyzed bladder and urine dribbling.
And the vital signs.
That is the critical differentiator. Viral infections like EHV1 or West Nile virus typically initiate a massive systemic inflammatory response.
A fever.
Exactly. The horse will spike a significant fever, often preceding the neurological signs. EPM, conversely, is an incredibly localized war.
So no fever.
Almost never. The horse's vital signs are almost always perfectly normal. No fever, normal heart rate, normal respiration. They're eating aggressively, they appear bright and alert, but their nervous system is systematically failing.
Which makes it terrifying for an owner. You're looking at a horse that seems fine, but its legs just aren't working right.
It's very confusing for the client.
But here is the most staggering statistic in the epidemiology data. The vast, overwhelming majority of horses exposed to this parasite never get sick.
True.
The research indicates that less than 1% of horses exposed to the sporocysts actually develop the clinical neurological disease EPM.
Less than 1%.
That's incredibly low.
It is. The equine immune system is, generally speaking, highly competent. When those sporozoids emerge in the gut, the immune system recognizes the foreign antigens. It mounts a robust humoral and cellular immune response.
It fights back.
Intensely.
Yep.
It deploys IgA antibodies in the mucosal lining and IgG and IgM antibodies in the systemic circulation. It neutralizes and clears the parasite before it ever has a chance to breach the blood-brain barrier.
So for that unlucky fraction of a percent, what goes wrong? Why does the fortress fall?
It is intricately tied to immunosuppression. The epidemiological risk factors outlined by the ACVIM point heavily toward immune modulation.
Like age.
Age is a primary factor. We see a bimodal distribution. It heavily affects young horses between 1 and 5 years old whose immune systems are still encountering and mapping environmental pathogens.
And older horses.
Right. Older horses over 13, experiencing immunosenescence, the natural decline of immune function.
And stress. The sources explicitly mention transport, heavy training, and parturition.
Stress triggers the release of endogenous corticosteroids, primarily cortisol. Sustained high levels of cortisol profoundly suppress the cellular immune response, specifically the T lymphocytes necessary to combat intracellular pathogens. If a horse is exposed to a massive load of sporocysts right after a grueling 15-hour trailer ride, their cellular immunity is compromised and the parasite slips past the defenses.
Which brings us to the most dangerous trap in this entire deep dive. Because if less than 1% gets sick, but exposures happen constantly, the diagnostic math gets incredibly weird.
It gets very messy.
This is part 3, the serum trap and the positive predictive value paradox.
My favorite topic.
Right. If I have a horse showing weird asymmetrical neurological signs, the easiest, cheapest, and safest thing to do is pull blood, run a serum titer. If the blood has antibodies for the parasite, I have my diagnosis right.
And that assumption is exactly how thousands of horses have been misdiagnosed and mistreated over the last 2 decades.
Ouch.
Relying on serum antibodies to diagnose active EPM is biologically and mathematically flawed.
Let's hit the listener with the numbers from the 2017 Journal of the American Veterinary Medical Association study. This was a massive, multi-center epidemiological survey.
Huge sample size.
Yeah, they pulled blood from over 5,000 completely healthy, non-neurological horses across the United States, and they tested that blood for antibodies to S. neurona.
And the results demonstrated the true scale of environmental contamination. The seroprevalence, the percentage of healthy horses carrying antibodies was astonishing.
High.
In the southern United States, 84% of healthy horses tested positive.
Wait, 84%?
84%. Even in regions previously considered low risk, the prevalence routinely exceeded 50%.
84% of healthy horses have the antibodies.
Yes. And this is where we have to conduct a masterclass on the concept of positive predictive value, or PPV.
Let's do it.
In diagnostic medicine, sensitivity tells you how well a test catches the disease. Specificity tells you how well a test avoids false alarms in healthy animals.
Right, the basic stats.
But clinicians and owners don't really care about those numbers in a vacuum. What they care about is the PPV. The PPV asks a very specific question. If the lab report says positive, what is the mathematical probability that my specific horse actually has the disease?
And the PPV isn't a fixed property of the test. It changes based on the environment.
Exactly. PPV is inextricably linked to the true prevalence of the disease in the population you are testing. Let's do the math on a theoretical barn to make this visceral.
Okay, lay it on me.
Let's say you have a highly accurate serum test. It has 90% sensitivity and 90% specificity. That sounds excellent on paper.
Sounds great. I'd trust a 90% accurate test.
Now let's test a population of 10,000 horses in that southern region where environmental exposure is massive. Based on the data, let's say the true prevalence of actual clinical EPM is only 1%.
Okay, so out of 10,000 horses, only 100 actually have the parasite actively destroying their spinal cord.
100 sick horses, 9,900 healthy horses.
Got it.
You run your 90% sensitive test on the 100 sick horses. It correctly identifies 90 of them as positive. These are your true positives.
Great. We caught 90 of the 100 sick horses.
But now you run that same test on the 9,900 healthy horses. Remember, the test has 90% specificity, meaning it has a 10% false positive rate.
Oh.
Because these horses have massive environmental exposure, the test is going to trigger on the harmless systemic antibodies. 10% of 9,900 is 990. The test produces 990 false positives.
Oh, wow. So you have way more false positives than sick horses.
Exactly. Your lab sends you back a total of 1,080 positive results. 90 are real, 990 are false.
That's a nightmare.
If you were standing in an aisle holding one of those positive reports, your positive predictive value, the chance that your specific horse is in the group of 90 and not the group of 990, is 90 divided by 1,080.
Which is, wait, let me do the math. That's like 8.3%.
Exactly. Despite using a test that is 90% accurate, a positive result on a blood test only gives you an 8.3% certainty that the horse actually has EPM.
That is insane.
You are mathematically almost 92% likely to be wrong if you diagnose off that serum result.
If you rely on the blood test, you are treating a horse with heavy, expensive neurological drugs, while the actual cause of their ataxia, whether it's a fractured cervical vertebra, a spinal tumor, or Wobbler's syndrome, goes completely ignored until it's too late.
It is a catastrophic cognitive bias.
It's the base rate fallacy playing out in real time in the clinic. Finding antibodies in the blood is like investigating a burglary.
Ooh, I like this analogy.
Right, so you find footprints on the public sidewalk outside the house. It proves someone walked past the house. It proves they were in the neighborhood.
Yeah.
But it does absolutely nothing to prove they actually broke through the front door, bypassed the security system, and are currently trashing the living room.
That is a perfect encapsulation. A systemic antibody response just means the mucosal immunity in the gut did its job. It does not prove the parasite breached the blood-brain barrier.
Makes total sense.
Now, we must add one critical caveat to the serum math. While the positive predictive value is terrible, the negative predictive value is phenomenal.
Right, the MPV. If the test comes back negative.
If the true prevalence of the disease is very low, that 1%, and your test comes back negative, the mathematics flip in your favor.
Because it's so rare to begin with.
Exactly. A negative serum test essentially rules out EPM with 99% certainty. If the blood is negative, stop looking for EPM and immediately start looking for other causes of the neurological deficits.
So to prove the suspect actually broke into the house, we have to look inside the house. We can't rely on the blood. We have to look at the cerebrospinal fluid.
Right.
Which brings us to part 4, tapping the spine.
To achieve a definitive ante-mortem diagnosis, a diagnosis while the horse is alive, the veterinarian must collect CSF.
The spinal tap.
Right. This is typically done via a lumbosacral centesis. The horse is sedated, and a long spinal needle is advanced through the skin, muscle, and ligaments of the lower back, entering the subarachnoid space of the spinal canal to aspirate the fluid bathing the spinal cord.
And the goal here is to find antibodies in that fluid. If we find antibodies inside the spinal canal, we prove the parasite crossed the blood-brain barrier.
We are looking for evidence of intrathecal antibody production. Intrathecal meaning within the spinal sheath.
Right.
If the parasite has invaded the central nervous system, The local B lymphocytes that reside in the neural tissue will begin actively manufacturing antibodies directly into the CSF, completely independent of the systemic blood supply.
But history shows us that testing the CSF is fraught with its own massive pitfalls. Like when EPM diagnostics were in their infancy, the gold standard test was the Western blot, right?
The Western blot was the cornerstone of early EPM diagnostics. It's an immunoblotting technique. They take the proteins from the Sarcocystis neurona parasite, separate them by size using gel electrophoresis, and then expose that gel to the horse's CSF. If antibodies to the parasite are present in the CSF, they will bind to the specific parasite proteins on the gel. Historically, researchers determined that if antibodies bound to a specific protein cluster known as the 17-kilodalton antigen, or 17-kiloretin, it was considered a definitive positive for EPM.
It sounds highly specific, but it had a fatal mechanical flaw, the bloody tap.
This is where the physics of the procedure collide catastrophically with the sensitivity of the test.
How so?
A lumbosacral tap is essentially a blind procedure. The veterinarian is navigating a needle through several inches of tissue using anatomical landmarks, not real-time imaging.
And there are veins in there.
The epidural space is lined with complex venous sinuses. It is incredibly easy to nick one of these microscopic blood vessels as the needle enters the spinal canal.
And if the horse is part of that 84% that has a sky-high level of antibodies in their blood from harmless environmental exposure, and you nick that microscopic vein, a drop of that highly concentrated antibody-rich blood spills directly into the pristine CSF sample you are collecting.
You have artificially contaminated the inside of the house with the footprints from the sidewalk.
Oh, man.
The needle physically introduced the systemic antibodies into the CSF. And because the Western blot is an extremely sensitive qualitative test, meaning it only asks a binary question, are the antibodies present, yes or no? It doesn't care how the antibodies got there. It detects them, and it turns positive.
The numbers in the ACVIM consensus regarding this contamination are what really shocked me.
Oh, the RBC count.
Yes. When researchers investigated why so many Western blots were coming back positive on horses that clearly didn't have EPM on necropsy, they found that the threshold for a false positive was microscopic. A false positive on the Western blot could be triggered by blood contamination as low as 8 red blood cells per microliter of CSF.
Let's contextualize what 8 red blood cells per microliter looks like to a clinician.
Please do, because it sounds impossibly small.
A microliter is 1/millionth of a liter. Human blood contains about 5 million red blood cells per microliter. If you have a CSF sample with only 8 red blood cells per microliter, it is completely invisible to the naked eye. The fluid will look like absolute crystal clear water.
And that is the terrifying part. Vets were drawing perfectly clear fluid, assuming it was a clean tap, sending it in, and getting a false positive.
Historically, the assumption was that a tap was clean as long as it wasn't visibly pink or xanthochromic yellowish from old blood breakdown.
Right.
The threshold for visible pinkness is around 300 to 500 red blood cells per microliter. When the data emerged that just 8 cells could ruin the Western blot, it invalidated thousands of previous diagnoses. It threw the veterinary community into a diagnostic crisis.
So knowing the Western blot was functionally useless because of these microscopic invisible bloody taps, researchers tried to find mathematical workarounds, right? I was reading about the albumin quotient, or AQ, and the IgG index.
Yes, the clinical pathology community attempted to mathematically index the contamination. Albumin is a relatively large protein synthesized entirely in the liver. It is never produced in the central nervous system.
So it's only in the blood.
Exactly.
Yeah.
Therefore, any albumin CSF had to come from the blood. The albumin quotient was calculated by dividing the CSF albumin concentration by the serum albumin concentration.
Okay, I follow.
The theory was that a high AQ proved the blood-brain barrier was compromised, allowing large proteins to leak through.
So if the AQ is high, it means the barrier is broken and the antibodies we see are leaking in from the blood, not being produced in the brain.
That was the theory.
Yeah.
But it completely fails in practice.
Why?
Because the albumin quotient cannot differentiate between true biological leakage caused by a disease process destroying the tight junctions of the blood-brain barrier and artificial iatrogenic leakage caused by the needle nicking a vein.
Oh, because blood has albumin in it too.
Exactly. Both events dump massive amounts of albumin into the CSF. Both events result in a highly elevated AQ. The index was mathematically useless for determining if the antibodies in the sample belong there naturally or were introduced by the clinician's needle.
I have to ask the most obvious question here. With all this chaos surrounding antibodies, passive transfer, and bloody taps, why don't we just look for the actual parasite?
It's a fair question.
In human medicine, if we want to know if a virus or bacteria is in the spinal fluid, we run a PCR test. We look for the literal DNA of the pathogen. Why are we relying on these convoluted antibody tests?
A polymerase chain reaction, or PCR assay, would theoretically be the holy grail. It amplifies and detects the specific nucleic acid sequence of S. neurona. If PCR is positive, the parasite is definitively there.
So why not use it?
But in clinical application for living horses, PCR on cerebrospinal fluid is virtually useless.
Why? If the parasite is eating the spinal cord, shouldn't its DNA be floating in the fluid?
First, the parasite is obligate intracellular. It lives deep within the neural parenchyma inside the actual tissue of the spinal cord or brainstem. It is very rarely floating free in the subarachnoid space where the CSF circulates.
Okay, that makes sense.
Second, when the host's cellular immune system does destroy a parasite, the released DNA is rapidly degraded by nucleases in the CSF, or phagocytized by macrophages. The window of opportunity to detect free-floating intact DNA in the fluid is incredibly narrow.
So the false negative rate is massive.
The false negative rate for PCR on CSF is unacceptably high. A negative PCR tells you absolutely nothing. Therefore, we must rely on detecting the host's immune response. We must rely on antibodies.
Which feels like we are back to square one. If the qualitative Western blot is ruined by an invisible speck of blood, the albumin quotient is mathematically flawed and PCR fails. How do we actually diagnose this disease?
This specific crisis forced the evolution of the current gold standard in EPM diagnostics. We had to abandon qualitative tests that just say yes or no. We had to transition to highly specific quantitative assays that can tell us exactly how much antibody is present and compare those concentrations mathematically to subtract the background noise.
Which brings us to part 5, the gold standard. Titer ratios and advanced assays, the absolute heavy hitters of modern diagnostics. IFAT and ELISA.
Exactly. IFAT stands for Indirect Fluorescent Antibody Test, and ELISA stands for Enzyme-Linked Immunosorbent Assay.
Big words.
Very big. But basically, these are quantitative tests. They yield a specific titer, a numerical value representing the concentration of antibodies.
Okay.
For S. neurona, modern laboratories primarily utilize polyvalent ELISAs that target specific surface antigens, specifically the Sensei-243 ELISA.
Yeah.
For N. hughesi, they use the RNA-Stage1 ELISA.
Let's unpack the biology of these tests because the elegance of the ELISA is fascinating. SAG stands for surface antigen. These are the specific proteins that coat the very outside of the parasite's membrane.
Think of the surface antigens as the parasite's armor, but also its unique fingerprint.
I like that.
The host's immune system recognizes these specific surface proteins and builds antibodies precisely tailored to bind to the epitopes on those SAGs.
So it's a lock and key.
Right. By using a polyvalent ELISA, which means the assay incorporates multiple different surface antigens, specifically SAG2, SAG4, and SAG3, simultaneously the test can capture a much broader range of the host's antibody response. It accounts for different genetic strains of the parasite, making the assay incredibly sensitive.
And IFAT differs because it uses the whole parasite rather than just the isolated surface armor, right?
Correct. The IFAT uses whole, intact S. neurona merozoites fixed to a slide. The patient's serum or CSF is applied. If antibodies are present, they bind to the whole parasite.
Okay, then what?
A secondary fluorescently tagged antibody is added, which binds to the patient's antibodies. Under a fluorescent microscope, the parasites physically glow green if the test is positive. The technologist then dilutes the sample repeatedly until the glowing stops. That final dilution is the titer.
But whether a lab uses IFAT or the polyvalent ELISA, the actual breakthrough wasn't just the test itself. It was the mathematical framework we applied to the results.
Yes.
The absolute game changer in this field is the serum to CSF titer ratio. This is the mathematical formula that finally solves the bloody tap problem.
The serum to CSF titer ratio is the cornerstone of modern EPM diagnosis. It operates on a fundamental physiological principle of the blood-brain barrier.
Which is?
Even in a perfectly healthy horse with an intact, uncompromised BBB, a minuscule, predictable amount of systemic IgG antibodies will passively diffuse across the barrier from the blood into the cerebrospinal fluid.
So there's always a tiny baseline of antibodies in the CSF, just from natural seepage.
Exactly. Because the concentration of antibodies in the blood is astronomically higher than the concentration in the pristine environment of the central nervous system, The normal healthy ratio between the two is very high. The serum titer will be orders of magnitude larger than the CSF titer.
Let's use our metaphor. The serum is the public street outside, and the CSF is the inside of the house. Normally, there are thousands of footprints out on the street, and maybe 1 or 2 footprints naturally get tracked into the foyer on the bottom of someone's shoe. A very high ratio of outside to inside.
But if the parasite has successfully invaded the central nervous system, we are no longer dealing with passive transfer. We are dealing with intrathecal production.
The B cells inside the brain.
Yes. The local B lymphocytes inside the brain and spinal cord recognize the parasite and begin actively manufacturing massive quantities of antibodies directly into the CSF.
They are building a weapons factory inside the house.
Precisely. When that localized manufacturing begins, the concentration of antibodies in the CSF spikes dramatically relative to the concentration in the blood.
So the ratio changes.
When you divide the serum titer by the newly elevated CSF titer, the resulting ratio drops significantly.
And researchers found the mathematical cutoff point.
Yes. For the sensagelysis, extensive validation has established a cutoff ratio of 100, often referred to as the C value.
The C value.
If you divide the specific serum titer by the specific CSF titer, and the resulting number is less than or equal to 100, for example, if the ratio is 50, it provides mathematically robust proof that the proportion of antibodies in the CSF is far too high to be explained by either natural passive diffusion or an iatrogenic bloody tap.
Wow.
It proves that intrathecal antibody production is occurring. It proves the parasite is actively established in the central nervous system.
That is just brilliant. It completely circumvents the panic of the 8 red blood cells because the math accounts for the blood concentration.
Exactly.
Even if you bleed into the sample, the ratio holds true because you are measuring the disproportionate localized production. And the data backing this up is ironclad. We're looking at the Johnson 2013 study published in the Journal of Veterinary Internal Medicine.
The Johnson study is critical because of its methodology. They didn't just compare tests against other tests. They compared the diagnostic assays against the absolute gold standard, post-mortem histopathological confirmation.
Necropsies.
Right. They evaluated horses that had been euthanized and physically examined the spinal cords under a microscope for parasitic lesions to definitively categorize them as diseased or healthy.
And when they applied the polyvalent ELISA to just the serum of those horses, the specificity was a dismal 50%.
Right.
It was a literal coin flip because of the massive environmental background exposure. But when they applied the serum to CSF titer ratio to those exact same horses,
the specificity jumped to a flawless 100%. The ratio mathematically eliminated every single false positive caused by environmental exposure and passive transfer.
And this was further corroborated by the Rainier study in 2016, which directly compared the IFAT against the ELISA ratios.
The Rainier study was a robust comparative analysis. They found that both the IFAT and the ELISA were excellent quantitative tools, demonstrating comparable sensitivity.
So both are good.
Yes. However, they concluded that the ELISA titer ratios exhibited slightly higher specificity.
Why was the ELISA better?
The IFAT was marginally more susceptible to false positives resulting from the passive transfer of high-titer systemic antibodies across a compromised blood-brain barrier.
Ah, I see.
This nuance is why the current ACVIN consensus statement so strongly advocates for the utilization of the specific quantitative serum to CSF titer ratios to confirm an EPM diagnosis antemortem.
So we have navigated the biological origins, the clinical chaos of the symptoms, the catastrophic traps of serum testing, the physical limits of the spinal tap, and the elegant mathematics of the titer ratios.
We covered a lot of ground.
We did. And we finally have a confirmed diagnosis.
Yeah.
We know mathematically that the parasite is actively destroying the central nervous system.
Yeah.
Now, how do we stop it? How do we save the horse? This brings us to part 6, chemical warfare.
The pharmacological approach to treating EPM has undergone a significant evolution over the past 20 years.
Let's hear it.
Historically, the primary line of defense was a synergistic combination of 2 antimicrobial drugs, sulfadiazine and pyrimethamine, commonly abbreviated as SDZ-PYR. These are FDA approved for EPM. But to understand their efficacy and their danger, you must understand their mechanism of action. They are metabolic poisons targeting the folate synthesis pathway.
Folate, as in vitamin B9, folic acid.
Exactly. Folate is an absolute requirement for the synthesis of nucleotides, the building blocks of DNA and RNA. Without folate, a cell cannot replicate its DNA and it cannot divide.
Right.
Now, the horse's cells can absorb preformed dietary folic acid directly from their environment. But apicomplexan parasites like Sarcocystis neurona lack the transport mechanisms to absorb preformed folate.
So they have to make it themselves.
They are obligate synthesizers. They must build their own folate from scratch using simpler precursor molecules like paraminobenzoic acid or PABA.
So if you shut down their internal manufacturing plant, the parasite starves to death at a molecular level, while the horse's cells, which can just absorb folate from their food, survive.
That is the pharmacological theory. Sulfadizine competitively inhibits the enzyme dihydroapatite synthase, which the parasite uses in the early stages of folate synthesis.
Okay.
Pyrimethamine inhibits a downstream enzyme, dihydrofolate reductase. Together, they create a sequential, synergistic blockade of the entire pathway. But this treatment protocol possesses incredibly critical and often counterintuitive quirks regarding the horse's diet.
This is the part that fascinated me the most. The literature explicitly mandates that hay must be withheld from the horse for several hours before and after dosing them with the SDZ-PYR suspension.
It's true.
Imagine the conversation with a horse owner. Your horse is neurologically failing, they need this life-saving drug, but you cannot let them eat hay, their primary fundamental food source, because the hay acts as an antidote to the medication.
It sounds crazy, but it's a profound example of competitive pharmacology occurring in the gastrointestinal tract.
How does that work?
Equine forage hay and pasture grass contains exceptionally high levels of PABA and other natural folate precursors. If you administer the diaminopyrimidine drugs into a stomach packed with hay, those massive quantities of dietary PABA actively compete with the sulfadiazine for absorption enzyme binding sites.
The hay literally outcompetes the drug.
It does. It nullifies its bioavailability and its therapeutic effect on the parasite. The timing of administration relative to feeding is critical for success.
And what about the other side of the folate equation? If we are introducing systemic metabolic poisons that interfere with folate pathways, aren't we risking collateral damage to the horse's rapidly dividing cells?
Oh, absolutely.
Doesn't this cause severe anemia or leukopenia?
It absolutely does. The therapeutic index, the margin between the dose that kills the parasite and the dose that becomes toxic to the host, is perilously narrow. Long-term administration of SDZ-PYR frequently results in bone marrow suppression, leading to anemia, neutropenia, and severe gastrointestinal disruption.
So the logical leap for an owner or a vet would be, okay, the drugs are causing folate deficiency in the horse. Let's just supplement the horse with a massive dose of folic acid.
Right, that's the instinct.
The horse absorbs it, protects its bone marrow, and the parasite, which can't absorb preformed folate anyway, still dies. It sounds like a perfect solution.
It sounds perfect in theory, but in practice, it is a fatal clinical error.
Fatal.
The ACVIM consensus statement issues a stark warning against this exact practice. In vivo studies have demonstrated that supplementing folic acid or folinic acid to horses receiving SDZ-PYR does not simply protect the horse. It actively negates the antimicrobial efficacy of the drugs against the parasite.
Whoa.
Furthermore, and far more dangerously, concurrent administration of folic acid with these specific drugs has been strongly linked to fatal toxicosis, particularly in pregnant mares, resulting in catastrophic congenital defects or fetal death.
The supplement intended to save them actually exacerbates the toxicity. That is terrifying.
Therefore, the consensus is clear. The use of supplemental folic acid in EPM-affected horses being treated with SDZ-PYR cannot be clinically justified.
Just don't do it.
Right. We must manage the anemia through other supportive means. Fortunately, the limitations and toxicities of the folate inhibitors drove the pharmaceutical industry to develop far superior, highly targeted options.
The newer FDA-approved anti-coccidial drugs, the triazine-based compounds, ponazuril and declazuril, commercially known to most horse owners as Marquis and Protozoal.
These compounds represent a monumental advancement in veterinary pharmacology because they abandon the folate pathway entirely.
A completely new target.
The triazines target a specific cellular organelle unique to epicomplexan parasites called the epicoplast, or plastid body.
What exactly is an apicoplast? It sounds like something out of a plant cell.
It essentially is. Evolutionary biology tells us that the apicoplast is the result of an ancient secondary endosymbiosis event, where the ancestor of these parasites engulfed a red alga.
An alga, like seaweed.
Yeah. The parasite repurposed the alga's chloroplast, the plastid not for photosynthesis, but for essential metabolic functions like synthesizing fatty acids and isoprenoids.
So the parasite has this weird, ancient plant-like organelle inside it that it absolutely needs to survive.
Exactly. And crucially, mammalian cells do not possess an apicoplast. They possess nothing even remotely similar to it.
That's
Therefore, drugs like pontogeril and diclageril, which specifically bind to and disrupt the metabolic processes of the apicoplast, are exquisitely toxic to the protozoan while remaining virtually harmless to the horse's cells.
The safety margin is massive.
The safety margin is vast. They effectively halt the parasite's intracellular replication without suppressing the horse's bone marrow. The development of the triazines revolutionized the treatment landscape, moving us from generalized metabolic poisons to targeted biochemical assassination.
Targeted assassination. I like the sound of that. But even with targeted assassination, we are still dealing with a parasite that is everywhere.
Right.
The environmental contamination is so widespread. Which brings us to the final piece of the puzzle, prevention. Can we stop this before the parasite ever reaches the blood-brain barrier?
Prophylaxis is a heavily researched area, utilizing a two-pronged approach of pharmacology and environmental biosecurity.
What's the pharmacological side look like?
Recent longitudinal studies have investigated the use of triazines as preventative agents on high-risk breeding farms. They demonstrated that administering an intermittent or daily low-dose regimen of diclageril to foals significantly reduced their seroprevalence rates.
Oh, that's interesting.
The drug essentially neutralizes the sporozoites in the gastrointestinal tract during the initial exposure, preventing the systemic infection from ever establishing a foothold.
But you can't just rely on medicating every horse every day, right? It has to come down to environmental management. We have to go back to the opossum.
Environmental management is the bedrock of prevention. You must break the biological chain of transmission.
Oh.
This means aggressively minimizing the risk of feed and water contamination by opossum feces. The epidemiological data is definitive. The likelihood of EPM outbreaks on a farm is reduced by more than a third simply by implementing strict wildlife exclusion protocols.
We are talking about highly practical physical barriers. Never feeding horses directly off the ground, elevating all feed tubs, storing grain in impenetrable sealed metal containers, not just open bins.
Exactly.
Ensuring all hay storage is secured against wildlife ingress, fencing out opossums from pastures and barns, and ensuring that all water sources are clean and protected from fecal runoff.
It is a holistic, comprehensive battle. It requires vigilance from the microscopic level of the apicoplast all the way up to the macroscopic level of securing the lid on the grain bin.
Let's bring this all together. Equine Protozoal Myeloencephalitis is an absolute master of disguise. It is a devastating, chaotic, neurological disease caused by a parasite taking a biologically fatal wrong turn, shifting its transmission from the opossum into the dead-end host of the horse.
Well said.
Diagnosing it requires clinicians to look past the useless, mathematically misleading serum blood tests, avoid the panic and physiological reality of the microscopic bloody tap, and dive directly into the cerebrospinal fluid, utilizing highly specific mathematical titer ratios, the quantitative ELISAs and IFATs, to prove definitively that the battle is happening inside the central nervous system.
And that summary underscores why this specific deep dive is such a vital exercise in scientific literacy.
It really is.
Whether you are a veterinarian analyzing a complex lab report, an owner noticing a subtle drag in a horse's hind leg, or simply a curious learner trying to grasp the nuances of medical diagnostics, EPM teaches us a paramount lesson.
Always question the test.
Always question the face value of a positive result. You have to understand the true prevalence of the population, the mechanical limitations of the assay, and the physiological reality of the biological barriers involved.
It is a masterclass in critical thinking, but as we wrap up, there is one final lingering concept straight from the Future Directions section of the ACVIM consensus statement that we need to address. And honestly, it is the most chilling part of the entire research stack.
I know exactly what you're talking about. You are referring to the hypothesis of persistence and reactivation.
Yeah.
We've established that in the vast majority of horses, the immune system successfully recognizes and clears the parasite from the periphery. We also know how to treat active infections in the central nervous system with triazine drugs. But the profound, unanswered question in veterinary neurology is this. What if Sarcocystis neurona is capable of establishing a persistent, silent, inapparent infection within the neural tissue.
What if it forms those dormant the sarcocysts deep in the brain or spinal cord of the horse, exactly like it does in the muscle tissue of the skunk?
Exactly. What if the parasite goes completely dormant, hiding within the immune-privileged environment of the central nervous system, just waiting for a moment of severe physiological stress?
Oh, wow.
A massive trailer ride across the country, a severe concurrent illness, or the natural immunosenescence of extreme old age. The stress causes a massive spike in cortisol, the cellular immune surveillance drops, and the dormant cysts suddenly rupture, reactivating the active destructive phase of the disease.
It's the exact same immunological mechanism as the varicella-zoster virus in humans. You get chickenpox as a child, your immune system fights it off, but the virus hides in your dorsal root ganglia for decades, completely silent. And then 50 years later, you go through a period of extreme stress, your T cells drop, and it erupts as shingles.
It is a terrifyingly parallel concept. And if that hypothesis is true, if the parasite can truly hide out dormant in the equine central nervous system, it fundamentally alters our definition of success.
Right. Are we actually curing them?
Are our advanced targeted treatments ever truly curing EPM? Or are we merely suppressing the active replication, forcing the parasite into a deeper, dormant hiding place, just waiting for the next inevitable drop in the horse's immune defenses?
Yeah.
It is a profound immunological question that researchers are actively struggling to answer today.
That is a staggering thought. I want you to ponder that the next time you see a horse peacefully grazing in a pasture, beneath that tranquil, powerful surface, an incredibly complex, microscopic war might be silently taking place, just waiting for the right moment.
It's entirely possible.
We started this deep dive talking about a broken X-ray machine and diagnostic muddy waters. And I think it's safe to say that while the ELISA Titer ratios have given us a much brighter, more accurate flashlight, the waters of equine neurology are still incredibly, wonderfully deep.
Indeed they are. The complexity is what makes the science so essential.
Thanks for jumping into the deep end with us.